Hello, good morning. Today we will learn about classification, common causes, clinical feature, and investigation of intestinal obstruction. According to site of obstruction, it could be a small bowel obstruction or large bowel obstruction, and as per presentation, it can be acute, chronic, acute on chronic obstruction, or subacute obstruction. And on the basis of blood flow, it may be simple obstruction or a strangulated obstruction. And on the basis of peristalsis, it may be dynamic type or adynamic type. In dynamic type, basically, peristalsis is working against a mechanical obstruction, and this mechanical obstruction can be intraluminal, intramural, and extramural. Further, in intraluminal, the cause may be impaction, foreign body, Bezoars, and Gallstones. And in intraluminal, mainly two causes occurs. First one is a stricture and second one is malignancy. And extramural causes are band and adhesion, which in fact is the commonest cause of intestinal obstruction. Next is hernia, volvulus, and intussusception. Adynamic is a condition in which peristalsis may be absent mainly in paralytic areas, or it may be present in a non-propulsive form in case of mesenteric vascular occlusion or pseudo-obstruction. This is the pie chart showing the common causes of dynamic intestinal obstruction and its incidence. You can see adhesion is the commonest cause of intestinal obstruction with the incidence of around 40%, followed by inflammation and carcinoma, and each having incidence of 15%. Rest are obstructed hernia, fecal impaction, and pseudo-obstruction. As you have seen that band and adhesion is the commonest cause of intestinal obstruction, so I would like to show you the image of band and adhesion which causes intestinal obstruction. Here also we can appreciate the band which causes intestinal obstruction. This is the second image which also showing the band which causes the intestinal obstruction. See here, this is a case of a strangulated small bowel loop, and cause of this strangulation is strangulated inguinal hernia, and you can see here how the color of intestine becomes black once the blood supply is compromised. And here we should know about the causes of strangulation, which may be external, in which hernial orifices and adhesion comes. Second one is interrupted blood flow, which result in the formation of volvulus and intussusception. Third reason of strangulation is because of increased intraluminal pressure, which causes closed loop obstruction. And fourth one is primary, in which mesenteric infarction. Please you must remember the causes of bolus obstruction, which are food, gallstone disease, Trychobezoars, Phytobezoars, estercolate, and worms. Food obstruction may occur after partial or total gastrectomy when unchewed articles can pass directly into the small bowel. Usually fruit and vegetables are particularly liable to cause obstruction, and its management is intraluminal crushing. Gallstone obstruction is also called a gallstone ileus, and this type of obstruction usually occurs in the elderly. Classically, there is impaction about 60 cm proximal to the ileocecal wall. Usually, patients have recurrent attack of pain. Our radiograph will show evidence of small bowel obstruction with the diagnostic air fluid level in the biliary tree. Its management is intraoperative crushing of the stone within the bowel lumen after milking it proximally. It's very important, please don't explode the gallbladder at this time. Trychobezoars and Phytobezoars may also cause obstruction. Trychobezoars are firm masses of undigested hair wall and occurs due to persistent hair chewing in a patient with diagnosis of psychiatric manifestation, while phytobezoars are firm masses of undigested fruit or vegetable, and predisposing factors for the occurrence of phytobezoars are high fiber intake, inadequate chewing, previous gastric surgery, hypochlorhydria, or loss of the gastric pump mechanism. Next is estercolate, which usually found in the small bowel but may occur in large bowel also. It's associated with jejunal diverticulosis or ileal stricture, and its treatment is same as that of gallstone ileus, that is milking and intraluminal crushing of the estercolate. Last cause of bolus obstruction may occur because of worms. Most common worm which causes obstruction in children is Ascaris lumbricoides, and children with these worms usually present with the clinical feature of a small bowel obstruction, but in advanced stage, some children may present with the feature of perforation and peritonitis. Its diagnosis is usually confirmed by the presence of worms either in stool or vomitus. And if worms are not seen in the stool or vomitus, the diagnosis may be indicated by the presence of eosinophilia or the sight of worms within the gas-filled small bowel loops on a plain X-ray. As band and adhesion is the commonest cause of intestinal obstruction, we should know about the common causes of intra-abdominal adhesion, which may be related to ischemic area and include site of anastomosis, trauma, or vascular occlusion. Next one is related to foreign material that may include talc, starch, gauze, and silk. Next cause is related to infection, which include peritonitis and tuberculosis. Under inflammatory condition is Crohn's disease, and last one is radiation enteritis. So my dear student, what are the factors that would limit the adhesion formation and consequently decreases the chance of intestinal obstruction? That are number one, good surgical technique, proper washing of the peritoneal cavity with saline to remove clot, minimizing contact with gauze and covering anastomosis and raw peritoneal surfaces. Now learn some important fact about bands. Bands may be congenital, like obliterated vitreointestinal duct, a portion of greater omentum, usually adherent to the parietal, and a string band following previous bacterial peritonitis. Now learn about acute intussusception. Intussusception usually occurs when one portion of the gut becomes invaginated within an immediately adjacent segment. It usually occurs in first year of life with peak incidence in between 5 to 10 months of age. About 90% of cases are idiopathic, but many are associated with hyperplasia of Peyer's patches in terminal ileum secondary to viral infection. In older children, the pathological lead points are Meckel's diverticulum, polyp, Hanok-Esculin purpura, appendix, or other. Now we should remember about the three different parts of intussusception, which are the entering or inner tube, the returning or mid tube, and the sheath or outer tube. And this outer tube is also called as intussuscipiens, and the entering tube is called as intussusceptor. Now remember the different types of intussusception, which are ileocolic, ileo-ileocolic, ileo-ileal, and colocolic. Among all these, ileocolic is the commonest variety in children and its incidence is 77%, while colocolic is common in adult. We can see the intraoperative finding of intussusception. This is the image of jejunal intussusception. Next important thing that we need to know is about volvulus. Volvulus is a twisting or axial rotation of a portion of bowel about its mesentery. It may be primary or secondary. The primary form occurs due to congenital malrotation of the gut, abnormal mesenteric attachment, or congenital bands. Example of this primary form include Volvulus neonaterum, cecal volvulus, and sigmoid volvulus. A secondary volvulus is the more common variety which occurs because of rotation of a piece of bowel around a acquired adhesion or stoma. Sigmoid volvulus is the commonest spontaneous type in adult and also known for the commonest cause of large bowel obstruction. Here, rotation nearly always occurs in anti-clockwise direction. It's very important to remember the predisposing factors of sigmoid volvulus. By this image, you can see the band of adhesion, overloaded pelvic colon, long pelvic mesocolon, and narrow attachment of pelvic mesocolon are the predisposing factor to cause sigmoid volvulus. Acute obstruction usually occurs in a small bowel obstruction with sudden onset of severe colicky central abdominal pain, early vomiting, distension, and constipation. While chronic obstruction is seen in large bowel obstruction with lower abdominal colic and absolute constipation followed by distension. In acute or chronic obstruction, there is a short history of distension and vomiting against the background of pain and constipation, and subacute obstruction implies an incomplete obstruction. It's very important to differentiate high small bowel, low small bowel, and large bowel obstruction by their clinical presentation. In case of high small bowel obstruction, patient having more vomiting at early stage of disease with minimal distension and little evidence of fluid on abdominal X-ray. Dehydration is maximum in high small bowel obstruction. On the other hand, in low small bowel obstruction, pain is predominant with central distension, vomiting is delayed, and multiple central fluid levels are found in abdominal X-ray. In large bowel obstruction, of course, distension is more an early presentation with mild pain and vomiting, and dehydration is the late presentation in case of large bowel obstruction. In inspection, you will find the abdominal distension, scar, and visible peristalsis. On palpation, a mass or tenderness or guarding may be felt. On percussion, you may get tympanic note or dullness, and on auscultation, the vowel sounds are high and increase in frequency. And advise all these basic and routine investigation, including full blood count, clotting profile, arterial blood gas analysis, renal function test, liver function test, blood grouping and cross-matching, plain X-ray abdomen in erect and supine position, ultrasonography, and CT scan with contrast if the patient is stable and his or renal function is within normal limit. Here you can see the erect abdomen X-ray which is showing air fluid level, and its characteristic shape is step-ladder pattern which is diagnostic for ileal obstruction. Second image is for supine position showing distended small bowel loop in the central abdomen with prominent valvula conniventes, and last image is of lateral decubitus view. This is also showing air fluid levels for intestinal obstruction. Here we can see the presence of ostration and peripheral distension in case of large bowel obstruction, while the presence of valvula conniventes and central distension in case of a small bowel obstruction. Look on this X-ray. What is the diagnosis? Here, colon is dilated for more than 6 cm. Effacement of haustra is located peripherally, and there is multiple air fluid level. So diagnosis should be large bowel obstruction. And also remember the rule 369, which implies that suspect obstruction if a small bowel dilated for more than 3 cm and large bowel dilated for more than 6 cm and cecum dilated for more than 9 cm. And this rule is called rule of 369. See, this one is the finding of cecal volvulus and this one is for sigmoid volvulus. See the image in case of intussusception. Here we can see an absent cecal gas shadow in ileocholic acid. On barium enema, a claw sign can be evident in case of intussusception. Role of CT, especially with IV, oral and rectal contrast is very important. With this triple contrast, CT can demonstrate the abnormality in the bowel wall, mesenteric vessels, and peritoneum. It can also define the level of obstruction, the degree of obstruction, the cause of obstruction, the degree of ischemia, and free fluid and gas. Before shifting the patient to CT room, please be ensured that your patient is hemodynamically stable with no renal failure and no previous allergy to iodine. In this axial image, we can see the dilated contrast-filled loop of bowel on the patient's left, shown by the yellow arrow, with decompressed distal small bowel loop on the patient's right, shown by red arrow. The cause of obstruction is an incarcerated umbilical hernia that can also be seen by green arrow. Although barium enema is useful in recurrent and chronic obstruction, but it should not be useful in a patient with peritonitis. Barium enema can be used to distinguish a dynamic and mechanical obstruction. We will discuss the treatment of intestinal obstruction in next class. Thank you.